are able. My name is Valerie Gold, and I'm so pleased to be with you here today. Today, this event where we'll be discussing BIPOC community college students is brought to you by the Substance Abuse and Mental Health Service Administration's New England Mental Health Technology Transfer Center, or MHTTC for short. We're going to go ahead and get started, although I know folks are still rolling into the room. So don't worry, you're not going to miss anything critical. If you're just getting here, we're going to warm up and then go through some introductions and dive into our action-packed discussion. Vanessa, could you advance to the next slide, please? Vanessa, can you advance the slide? Thank you. That's great. So our MHTTC is a collaborative that is led by Yale University's Program for Recovery and Community Health, C4 Innovations, which is where I work, the Harvard University's Department of Psychiatry, and the Center for Educational Improvement are other key partners of the MHTTC. And we are very, very fortunate to have our project director, Maria Restrepo Toro, joining us here today. I just want to make sure she's in the room before I call on her. Oh, good. There you are, Maria. Would you like to share a little bit about our MHTTC and key projects, or would you like me to jump into that piece since I know you're just getting settled?
Go ahead. Welcome, everybody. It's a pleasure to be working with you. Go ahead.
All right. Thank you, Maria. Vanessa, could you advance to the next slide, please? Great. So the New England MHTTC works across all 6 of the New England states and beyond to advance evidence-based practices to promote mental health recovery, supporting the mental health of young people and students, and advancing equity, inclusion, and access to culturally responsive and culturally informed care. Our partners at Harvard do incredible work around early psychosis, and we are also engaged in several collaborative efforts focused on suicide prevention and sharing promising practices around peer support, among other efforts. I hope you will visit our website. It's constantly changing, and sign up for our newsletter to learn more about what we do and to stay in touch. Next slide, please. So our goal today is to focus on understanding and responding to the mental health needs of BIPOC community college students. This is such a difficult time for all of us, and in many ways, it's an especially challenging time for BIPOC students who are working towards their educational goals at community colleges. We know that so many of these students are juggling coursework alongside lots and lots of other responsibilities within the context of the pandemic, its social and economic impact, and the myriad other challenges that they face daily, including systemic racism. We are incredibly grateful to have you all here today and to share what you are already doing to support students, to identify shared challenges and priorities, to network, and to tell us what we as the MHTTC can do to support your critically important work. So let's start with some introductions, and I'm going to try and move us through these quickly since I know there is a lot to talk about in our limited time. I'll go first, and then I'll ask the other MHTTC team members and our expert advisors who helped us to plan this event to introduce themselves. And we'll all follow this same format just to keep things moving quickly. I'll call on folks too so that there's no confusion over who's going next. So as I mentioned at the top of the hour, my name is Valerie Gold, and I'm a senior advisor with the MHTTC and the director of training and technical assistance at C4 Innovations. One thing that I'm hoping to get out of this meeting is a better sense of how our MHTTC can support the amazing work that so many of you are doing moving forward. So Maria, could you go next and share your name and role and one thing you're hoping to get out of this meeting?
Absolutely. So good afternoon, everybody. My name is Maria Restrepo Toro, and I am the co-director of the New England Mental Health TTC, and I am so delighted to be here today. We're really hoping, one of the things I am hoping to get out of this is really a targeted outreach to Latino students and communities, community colleges, and delighted to have my BU partners be part of the group in that effort. Thank you.
Wonderful. Thank you, Maria. Vanessa, could you go next?
Sure. Hi, everyone. My name is Vanessa Vronsky. I'm a project coordinator with C4 Innovations and the New England Mental Health Technology Transfer Center. And I'm excited to be here and help out with the technology today.
Thank you, Vanessa. And Lee, could you introduce yourself as well?
Sure. Yep. My name is Lee. I am here to assist Vanessa with the technology. As you know, more people on it is the better, and we are here to help you. So if you have any technical issues, please throw them into the chat, and we are here to help.
Wonderful. Thank you both so much. Dory, could you go next, sharing your name, role, and one thing you're hoping to get out of this meeting?
Sure, thank you. It's so nice to be here with you all, and I see some familiar faces. My name is Dory Hutchinson, and I'm the Director of Services at the Center for Psychiatric Rehabilitation at Boston University. And I'm here really to learn and to listen deeply and to hear what the challenges are and how we can move forward together in a collaborative effort.
Wonderful. Thank you so much, Dory, for being here and for lending your expertise to the planning of this convening. Juan, could you go next, please?
Sure. Hi, everybody. My name is Juan Leon Parra. I work with Dory Hutchinson and my colleague Chelsea Cobb, who's joining as well. I'm a training associate at Boston University's Center for Psychiatric Rehabilitation, and I'm most interested in immigrant students' experiences and how well community colleges are doing it and supporting and implementing best practices during these very difficult times.
Thank you, Juan. It's great to have you here. John Delman, could you go next, please? Oh, John, I think you're on mute.
There we go. Hey, everybody. I'm Jonathan Delman. I coordinate technical assistance for Intermath Research Center. At the spot in African Spain. Hope to learn if I can support the college and I'm really proud so I want to do it quickly.
Thank you, John. We're so glad to have you here. And I think there's some audio issues going on, which hopefully Lee can help you with figuring out as we keep going with introductions, since we definitely want to hear what you have to say throughout the discussion today.
I'm on it.
Thank you, Lee. Justin, could you go ahead and introduce yourself next, please?
Oh, I'm sorry. I'm sorry. I thought you said a different name. I apologize. Hello, my name is Cherry Applebaum. I am an intern for Lisa Carter at Project Access at RCC. I am hoping to get out of this meeting that new knowledge about what goes on to really support mental health in a setting like this one, especially for BIPOC students. I am an up-and-coming, aspiring art therapist, so this is right up my alley. And I really hope I can learn a lot about like behind the scenes and the kind of educational and kind of clinical kind of setting that goes on that that is all being revealed to me now. So.
Wonderful. Well, it's great to have you here. And why don't we move right from you to Lisa?
Good morning, everyone. My name is Lisa Carter, and I am the Director of Project Access at Roxbury Community College. And we serve a commuter, student. So therefore, they're balancing all of life's pressures. Some of them are parents, or they're taking care of elder parents, and they're trying to juggle all of that, as well as the other socioeconomic challenges that they're facing. And it's all compounded now with COVID. And we're certainly seeing an uptick in students that have been reaching out for support for various issues and the mental health challenges that are now being really highlighted based on, the social aspects of not being able to access family and isolation, et cetera. So I'm hoping to learn how we can do more to help the students.
Wonderful. Thank you for being here. Brian, could you go next, please?
Good afternoon, everyone. My name is Brian Mitra. I'm here as a subject matter expert with the JED Foundation. So providing perspective on community colleges. By day, I'm the Dean of Student Affairs for Kingsborough Community College out in Brooklyn, New York, part of the City University of New York. I'm really happy to be here, just kind of listen in on some of the challenges and some of the things that have worked well in this transition. I know some of the, I definitely know and can speak to some of the challenges of the rapid transition to remote learning and some of the things that we're facing right now with our student population. But I'm curious to learn from our colleagues here today. Thank you.
Thank you, Brian. It's great to have you here with us today. So we heard from John Delman. I'd love to hear from John Dunkel, please.
Good afternoon, everybody. Thank you, Valerie. My name is John Dunkel. I am the Senior Clinical Director for Higher Education of the JED Foundation. And if you're not familiar with the JED Foundation, it's a nonprofit organization that is focused on promoting youth and young adults' mental health and suicide prevention. And I've been here about 8 months now in my role, but prior to that, I was at Northwestern University for 25 years in their counseling center, and I was the director. I'm a psychologist by training, and I'm really looking forward to the discussion today. I'm hoping to really learn from all of you how JED can support community colleges, and more particularly BIPOC community college students. I have a special place in my heart for community colleges because my first degree was from a community college in upstate New York. So thank you.
Thank you. We're just thrilled to have you here. Chelsea, could you go next, please?
Hi, I'm Chelsea Cobb. I work at the Center for Psychiatric Rehabilitation with Juan and Dory, and I am really just here to listen and learn, and hopefully better see how I can support not only our students, but connect with other resources.
Wonderful. Thank you so much. Maura, could you go next, please? You may be on mute. All right, I'm going to move on to another name and loop back. And I really appreciate I should have asked for this in the beginning. I need a little bit of grace in terms of titles and pronunciations. I know that many of you who are joining us today are doctors, and I'm just jumping right into first names to save time and minimize my mangling. So thank you for allowing me that. Could we hear from Melissa next, please?
Hi, everyone. I'm Melissa Manzi. Happy COVID. I am working at Mount Wachusett Community College in Gardner, Massachusetts. I am a licensed mental health clinician, the only one for 3 campuses. So I am really eager to hear what other campuses are doing and find out any helpful tidbits for me. So thank you very much for inviting me.
Well, thank you for being here, Melissa. You must be incredibly busy with 3 campuses. And I can only imagine what you might be giving up for this time. So we're going to make it worth your while. Now we have 2 people named Amy with us today. Maybe we could start with Amy Gatto.
Sure. My name is Amy Gatto. I am a senior campus program manager at Active Minds. And I'm here today because it seems like a lot of our work has taken us into the community college space recently. And a lot of what we've been doing has been supporting our BIPOC students.
Well, thank you. It's great to have you here, Amy. Next up, could we hear from Tanya? Tanya,
hello. Can you hear me?
Now we can, yes.
Okay, great. Yes, I am Tanya Bass. I'm the Senior Health Equity Manager at Active Minds. I'm actually new in my role, so I work with Amy and just trying to get more information as I can see how this information will inform my role at Active Minds. Glad to be here.
Well, welcome. We're very happy to have you with us. Amy Stewart, could you go next, please?
Happy to. I'm Amy Stewart. I'm really excited about the topic and very interested in the topic. I've been working for about 21 years at the Community College of Vermont. By training, I'm a clinical social worker at CCV. However, I'm an academic advisor full-time. I also work in accessibility services, providing support to students with documented disabilities and creating accommodation plans. at CCV Winooski. We do have 12 centers across the state. In Winooski, however, we're serving about 20% global majority students. Black, Indigenous, and people of color, as well as a fair number of immigrant students. And while I have one student in mind as I'm participating today, I do hope to learn a little bit about supporting advisees and the rest of our staff who serve them. Thanks.
Well, it's great to have you here. And I see a couple of MHTTC colleagues have just joined the room as well. Not just, but as we've been talking. Michelle, would you like to say hello and introduce yourself, please?
Hi, everyone. Thanks. I'm Michelle Friedman-Yakubian. I'm a clinical psychologist, and I'm part of the New England MHTTC team. And my main interest for participating in this meeting today is related to my other hat as the clinic director of a program called CEDAR, which focuses on working with young people who are showing signs that they might be developing psychosis. And we really depend on community partners to help kids who need us to find their way to CEDAR. And I've been to a lot of colleges in our area, in the Boston area, but I haven't done much work in the community colleges, and I'm really aware that that's an underserved group that very likely sees a number of students who could benefit from our early intervention services, but who aren't necessarily knowing about us at the right time. So interested in just mostly listening and hearing from folks working with this area.
Thank you, Michelle. And Martha, could you go next, please?
Hi, everyone. My name is Martha Staley, and I am the site coordinator for the School Mental Health Initiative for the New England MHTTC, and I work with Maria Restrepo-Toro at Yale Program for Recovery and Community Health. So I'm very happy to be here in order to support this wonderful work and learn more about how we can work with be part of the initiative that I'm working on, which is K through 12 students. And yeah, I'm looking forward to listening and learning. So glad to be here.
Wonderful, thank you. Justin, could you introduce yourself now?
Hi, everybody. Good afternoon. My name is Justin Heinze. I'm an assistant professor in the School of Public Health at the University of Michigan. I'm here representing the Healthy Mind Study and the Healthy Mind Network. So my goal for this meeting is to share some of the data that we have and just promote awareness that it's available for people to use. I think there's already some partnerships or some connections between what I've heard from these introductions and our study, including one of our principal investigators is at BU. I know we have worked with JED and we work with Active Minds as well. So there's lots of connections here and I hope to bridge some more. So thanks for having me.
Oh, we're so grateful to have you here. And Julie, I think you just came into the room, but I'd still love to put you on the spot and ask you to share your name and role and one thing you're hoping to get out of this meeting. Julie, are you on mute? Oh, well, we can come back. Is there anybody who has not yet had a chance to introduce themselves? Okay, if not, or if folks are just joining now and don't want to speak up, please go ahead and introduce yourself in the chat. We're just thrilled to have you all here, and we're going to dive in. Why don't we advance to the next slide so I can give you a quick preview of our agenda. We are going to start with a presentation from Justin Heinze. We're very excited to hear the context that he'll provide around what the national data is telling us from the Healthy Minds Network study. From there, we're going to move into 4 breakout sessions where we'll be going through some moderated conversation to explore several of the issues that several of you have expressed interest in exploring during this event. So that's great. A number of folks submitted questions in advance of this convening, so we've used that to help us develop the question guide for our breakout sessions. Following those sessions, we'll take a short break so everyone can rest their eyes, stretch, do whatever you like, and then come back to join us for a facilitated large group discussion where we try to walk away with some key points to take with us and recommendations for the MHTTC. So without further ado, I would love to turn things over to you, Justin, for you to guide us through the data.
All right, thank you, Valerie, and thank you folks again for joining us this afternoon. So as I mentioned, my name is Justin Heinze. I'm here along with my colleagues from the Healthy Minds Network. I especially want to mention Daniel Eisenberg and Sarah Lipson, who are the co-principal investigators for this study. The goal today here is to start with a little bit of an introduction about who we are, and then I want to run through some of the data, and I'm going to start broad and narrow in. So I'm going to display some of the trends that we've seen over the last maybe 10 or 12 years, and then I want to share some about what we know of our respondents identifying as students of color or have non-majority identities, and then finally kind of really hone in on some specific data related to community colleges and specifically students of color attending those schools. So if we could have the next slide, please. Okay, so on a broad scale, the Healthy Minds Network is focused on how can we invest most effectively in mental health and well-being for college students. We do think of it as an investment because we understand that there are limited resources, and that could be not just financial resources, but people's time on campuses. And so how can we make the best use of resources to improve student health? And for us, the answer tends to be starting from the bottom here, and the goal of collecting as much descriptive population level data as possible so that we can inform the design and evaluation of programs and interventions. And from there, we can help schools make their most informed choice about what's going to work the best for their communities. And I want you to see the bi-directional arrows there, and that this is not university researchers coming in and saying this is how things need to happen, but it really is a partnership with not only researchers, but practitioners, administrators, policymakers, and students themselves, all having a voice. Next slide, please. So the network has been developed over the years. It began with Daniel Eisenberg in about 2007, and since then has expanded in our partnerships and our co-investigators. But our primary goals here, you see, are producing knowledge through research, and we're distributing that knowledge, which seems like it might be a fairly straightforward task, but we find again and again that the dissemination of this information can be a holdup. And so we're trying actively to increase our ability to make this data available, make it accessible to participating schools as well as others who might be able to glean important information about student mental health from our data. And then ideally, the end goal is certainly to translate that data into practice. Next slide, please. So the foundation of the network really was the original Healthy Minds study that I'll talk about. Let's see here. I'm seeing hopefully folks are seeing this map of different locations. So it began in 2005. It's an annual web-based survey. It's primarily cross-sectional data, although we do have some longitudinal cohorts. But over the years, we've had more than 300 schools, some which have participated consistently or every other year, reaching over 300,000 students. The approach is to take a random sample at larger institutions of students. At smaller institutions, we try to get a more inclusive or representative sample if we can, but we understand that there are limitations to our sampling process, but doing the best that we can to have an accurate picture of each participating institution, which is then aggregated up to the national level. The surveys take about 20 to 30 minutes to complete. I'll acknowledge up front that that's research speak. I like to think that they take 20 to 30 minutes to complete, and we do try to think about participant burden, but we understand that collecting this information takes time and that there is a cost to it. So we try to be sensitive of that. But at the end of the survey, we do try to provide resources for our students about how they can access services or learn a little bit more based on some of the information that we've heard from them. Next slide, please. So the core of the Healthy Mind study includes 3 modules that we collect from anybody who's participating. So those would include demographic information, mental health status, so these would be things like depression, anxiety, and then a key part of what we do is service utilization and help-seeking behaviors as well. So we want to understand whether students have access to services on their campus, whether they are able to approach or whether they see stigma on campus that might present barriers for their service utilization. But we ask all of our participating students and institutions those 3 modules. Over time, we've developed a series of auxiliary modules that students can, or that institutions can opt to include as well. So the goal is to try to be specific to the needs of the institution. If they believe that their students might be struggling with substance use, we can bring in a substance use module. If there is concern about resilience and coping, we can bring in a resilience and coping model. And again, the core of the survey stays constant over time. The modules, we try to be as responsive as possible. Next slide, please. As an example, just this past year, we've developed a COVID-19 module. So recognizing from our partners that students were struggling during the pandemic, we worked with the American College Health Association to pilot and then implement in the spring and fall a module around specifically how has COVID affected your mental health and your academics. Have you missed school because of your own illnesses or family members? Has trauma associated with the pandemic impacted your mental health? Those type of things. Has service utilization changed based on COVID and how it's been developing? So just an example of how these modules come into being. We typically see a need, or schools and partners communicate a need, and then we try to develop something that can be responsive. Next slide, please. So I won't spend too much time on this, but in those core modules, just some of the measures that I'm going to be presenting over the next few slides. So some of the key outcomes that we'll report in our national data reporting, and then we also have tailored reporting for each institution. So some of the highlights that we will bring to those reports are depression, overall depression, anxiety, eating disorders, suicide ideation, and non-suicidal self-injury, stigma. So some common constructs that we think are important enough that they're always going to appear. But then we also give institutions and anybody who's interested in accessing the data the ability to drill down a little bit further. But these are some of the measures, or some of the data that I'm going to present is going to be based off of these measures. And we can talk a little bit more about them in the questions if people have them. Next slide, please. Maybe one slide before. I'm on how HMS data are used to create change. There we go. So here, just so that we're all on the same page, and I would love to hear at the end of this how we can work with you to do so. A lot of the strengths that we find for the Healthy Mind studies is the ability to raise awareness around mental health and campus resources, not just for the students attending, but for the broader public at large, to understand that mental health is a concern for our college students, and it's not just something that's common for those who decide to pursue post-secondary study. We need to try to assess the need for program and services. So if there is a need on campus, can we help schools identify what that need is, and then they can tailor their efforts based on those needs. We want to be advocates for mental health resources, services, and programs on campus. And you'll see that's one of the things that we struggle with. I'm sure folks on the call see this as well. There's so much need and so much demand, and often scarce resources in which to do that. So we want to make that problem explicit so that we can find operational solutions to that. Evaluate existing programs. So for our repeat participants, if they implement some strategy or program to improve mental health on campus, if we have multiple years of data, we can see at least at the best population level that we can estimate, do we start to see some of those changes? We help schools do some benchmarking. So if they are interested to see how they are performing relative to their peers, we can provide some of that information. And then to the extent that we can as well, we're happy to have our data utilized in grant applications or policymaking decisions. For us, again, getting back to that dissemination point, we don't want our data to just sit there on the website. We want people to actively use it, download it. It's free. We're trying to do our best to make it as accessible to everybody as possible. Next slide, please. All right, so as I said, I'm going to start broad and then start to narrow in. So I'm going to talk about some trends in the data that we're seeing. You'll that I have 2007 to 2019 here. The reason being that 2020, we're still starting to collate and aggregate that data. I'll give you some numbers from 2020, but we also recognize that with COVID, there's a chance that it could be an outlier. But as you'll see, talking through these trends, the data that we're seeing from last year is kind of on par with what we might be expecting here. So this very first one is severe depressive symptoms. You'll see that there's this increase over time from 2007 up to 2019. And in 2020, actually, the percentage was 21. These were students who screened at 15 or above on the PSQ-9. So this would correspond to what's typically considered moderate depression. Severe depression, I think, starts, the threshold is about 20. These are self-reported depressive symptoms through the PSQ-9, but we have seen this concerning trend over time, especially starting about 2014, where the percentage of students reporting has gone up a fair amount and seems to continue to keep rising. Next slide, please. For positive, I'm now looking at positive screen for any depression. So this would be a little bit lower threshold, which is why you can see the numbers jumping up a little bit. So this is anybody who scored 10 or more on the PSQ-9. This would be kind of the lowest threshold for screening for depression symptoms, following a similar trend jumping up between in 2017, 2018, before leveling off a little bit. In 2020, in the fall, that number was 39%. So if there is a COVID influence, it's only making this problem a little bit worse for students. Next slide, please. Anxiety symptoms, this is using the GAD-7, is also seeing a similar trend. Again, 2016, 2017, and maybe we can talk about why that could have happened, thinking about some of the socio-political things that might have been happening in that year, but we do see this increase that's similar to depressive symptoms and anxiety symptoms as well. Next slide, please. So just like with the depressive symptomology, we also have the first slide of anxiety was more severe, a lower threshold for a positive screen for anxiety. We see that almost up to a third of our students are reporting at least a low screen for general anxiety disorder. That number in fall of 2020 was 34%. Next slide, please. And here we see some data we haven't collected quite as long, although it does go back to about 2013 now. The presence of eating disorder symptomology is also increasing on campuses. We see now that up to 1 in 10 students or respondents are reporting these symptoms. It was about 11% in 2020. Next slide, please. Considering non-suicidal self-injury, given that NCSSI or NSSIs are associated with a variety of clinical disorders, we're not surprised to see this number increasing, but we do see, in fact, from 2009 up to the most recent year, 2020, I think was around 23%, but a consistent increase in self-injury over the last 10 years or so. Next slide, please. Suicide ideation also increasing across our general population of students over the last 10 years. Next slide, please. Now here's kind of flipping on its head. Here we have those reporting that they sought or were utilizing therapy or counseling services. So, and a positive here, we're seeing more students having access to service. The underlying trend here, whether that's because more students are requiring service or more students are having access to service, is difficult to tease out. But generally speaking, we see about a third of students telling us that in the past year or the year that they took the survey that they've had access to survey. And then critically, next slide, please. For those students that have screened positive, we also asked or we tried to assess whether or not they've had access to services. And you can see of those that screen positive, only about a third are telling us that they have had access to services. Now, we don't necessarily say that services are required. There are a lot of different ways that students may choose to cope with their challenges. but at the same time, we would like to see those numbers continue to increase, although there has been a steady increase since about 2009, 2010. Next slide, please. And although we don't necessarily think of positive has to be a polar opposite to other symptomology, we are seeing that positive mental health, or what we'll call flourishing, has been decreasing since we started assessing in about 2012. Such that prior about 60% of students reported positive mental health, whereas now that number is closer to about 40%. Next slide, please. Now, one promising trend we are seeing is within our stigma data. So this is asking respondents what they think of someone who is seeking mental health services. And we saw that number was fairly low a decade ago, and it continues to go down, although I'll show you that there are some differences by respondent identity that might be influencing some of these numbers. But generally speaking, stigma seems to be decreasing across our sample. In 2020, it was about 6%. Next slide, please. Keeping those numbers in that last slide in mind, which were around 6%, this is how I might think of others seeking mental health services. When we think about other people and what they think of mental health services, you can see that this idea around stigma and mental health is still very present on campuses. So students think that other people view mental health services and access more negatively than we would hope. Next slide, please. Are you seeing reasons for not seeking treatment?
Yes.
Okay, great. So just some of the reasons that people report for not seeking treatment, either choose to deal with the issues on their own, perceive stress, and so trying to debunk this myth that stress is a normal part of college, and therefore we shouldn't be prioritizing. Still with me?
Justin, you were fading out a bit. Could you repeat yourself?
Oh, just the reasons for not seeking treatment. I'll let folks read them, but so just some of the reasons why students report they did not decide to seek treatment. And thinking about places where there's an intervention, for example, trying to debunk the myth that stress is a normal part of college and therefore, feeling sad or lonely or isolated is what everybody goes through. So trying to promote those resources and understandings for students. Next slide, please. So continuing to funnel, so we started broad trends. Now let's move down to specifically some of our non-majority populations relative to our white students. Here you have some of our 4 main outcomes: depression, anxiety, eating disorders, and suicidal ideation by race and ethnicity. So I flagged, even though I have the bolded, that's just to draw attention where there are differences. When we have large samples, if we want to talk statistical significance, huge samples, small standard errors, so these probably are statistically significant. But ideally, we would have a representative enough sample that these are almost population level estimates. And we do believe that there are some important differences in, for example, depressive symptomology, anxiety symptoms among our BIPOC students relative to white students. Next slide, please. So related factors that we just want to highlight. So some experiences of discrimination. Notice for African-American students are reporting some of the highest experiences. 2 out of 3 students, African-American students, are reported some form of discrimination. We recognize that there are both overt and some covert bias. Intersectionality, so our BIPOC students that might also identify as LGBT might be experiencing discrimination in multiple contexts. There are unique challenges that our BIPOC students are facing in college that could be related to some of that disparity in symptomology that I reported in the last slide, in addition to just the natural stress process of attending college and balancing all those new responsibilities and the emerging adulthood storm and stress, if you want to buy into that argument. But some of the protective factors that we find, inclusive environments, physical spaces and organizations for students, and then counseling staff. Next slide, please. Here, a primary thing I wanted to highlight is, I mentioned a little bit earlier, these ideas around stigma and that there could be group differences. Note here, this is help-seeking attitudes and behaviors. And this is something that we've seen across our data that our Asian American students tend to report higher levels of stigma around mental health services and might be less likely to seek out services. Next slide, please. Just to think about US citizens versus international students tend to report more personal as well as perceive more stigma than US students. Next, please. And then also our gender minority students and sexual orientation, we see pretty consistently, as I imagine folks have seen across the data, that gender minority students suffer from some of the highest levels of depression and anxiety, eating disorders, suicidal ideation. Next slide, please. And just like with students of color, students that identify as gender or sexual minorities do face discrimination, and we think many of the same issues that might be affecting our students of color could also be affecting students that are non-majority in terms of gender identity and sexual orientation, with a couple of unique challenges, for example, things like housing, policies that are on campus, as well as policies that are happening and conversations that are happening at the national level. Next slide, please. How am I doing on time here, Valerie?
You're doing fine. We can shift things around a bit, and this is such information.
Okay, I'm almost there. I'm almost to the community college, or the reason why we're all here, folks. So suicide ideation by gender identity, but just wanted you to see that first of all, we do see much higher levels relative to their cisgender peers, but even within gender minority categories, the distribution is relatively even. So there's concern across many different gender identities about their suicidal ideation. Next slide, please. And then thinking again about stigma and perceived stigma, the difference between personal stigma versus what they think other people think is striking to me. Next slide. So I know that was a lot of data to go over in a short amount of time. I just wanted folks to see where we were going from a trend perspective, to see some of those increasing trends, to see that BIPOC students and gender and sexual minorities tended to have a larger share of the mental health burden. And we're going to see that reflected in our data specifically from community colleges. Next slide, please. So I was able to pull data from our 2019-2020 year, which was about 90,000 students, 7,000 of whom attended community colleges. So you have to take this with a little bit of a grain of salt. We're extrapolating from about 7,000 participants here, but what we do see, so here are these key outcomes again: depression screen, anxiety screen, therapy utilization, and in parentheses, if you screen positive for either depression and anxiety, do you have access to services, or did you access services at the time that you took the survey? And then suicidal ideation. And you can see relative to the national sample, community college participants reporting more positive depression screens, anxiety screens, less therapy utilization, and even if they had a positive screen, less therapy utilization, and higher levels of suicide ideation. Now, within community college participants, breaking down by race and ethnicity, we see some differences between Black, American Indian, Indigenous, and Alaskan Native participants, those identifying as Asian, Hispanic or Latinx, Pacific Islander, and Middle Eastern. I'll just give folks, because I know this is where folks want to, the purpose of the call, just give you some time to take a look at this. I flagged those cells that are higher than the national data, or in the case of therapy utilization, a little bit lower than the national data. For reference, for community college students who identified as white, depression was about 41%, anxiety was about 36%, therapy utilization was 29 and 38% respectively, so a little bit higher, and suicidal ideation was about 18%. So white students are hanging pretty close in there with the community college averages or total. Next slide, please. And then here we have suicidal ideation, non-suicidal self-injury, flourishing, and academic impairment. So this is people telling us that for more than a week, their mental health has impaired their ability to be students or to be productive students. So we see once again that for community colleges, the population tends to be higher suicide ideation and self-injury than the national sample. Flourishing is right around the same, and academic impairment is roughly the same. But as soon as we get into the breakdown by race and ethnicity, we start to see some of those differences there. And that's what I have. So thank you for listening. I'm happy to take some of your questions again. We know this data is not perfect, but we want to try to share this data, to think critically about this data, and to make it useful for folks who are interested. So I'd be happy to hear your feedback or again, answer any of your questions. I thank you for your attention.
Justin, thank you so much. I know we had a couple of questions coming in through the chat as you were speaking. And yes, Maura, we will be sending around these slides as well as some additional resources following the meeting. I saw some questions come in from John Dunkel, so I'd love to invite you to start off with your questions and just some overall parameters for folks. We have about 8 minutes for questions here, but if there are others, we can track and follow up with those afterwards as well. John, would you like to start us off?
Well, actually, I have a new question, so I won't do the other ones. Thank you so much, Justin. This is very helpful and very informative. I'm wondering if the BIPOC community college student data you just shared, what the age, how that compares to the national sample. Are they older? Are they about the same age range, same mean? Because, having worked in college setting for a long time, the older students tend to have more of a history. So I'm wondering if there's also a piece of that there. I'm just curious what the age range was.
Yeah, I'm sorry, I don't have a specific range for you, John, but you're right. I would say in general, our community college population tends to be older than the national sample average. I'm happy to run that data for this sample though, and we can share it with Valerie and she can disseminate.
Yeah, okay, thank you. And that would lead me to believe that they probably have a lot more stressors as well, including family and other types of things, obviously. So thank you.
Yeah.
Other questions for Justin?
Hi, Justin. Thank you so much for the information. I just had a question. How was the survey distributed? I'm at a community college in Boston, and we've done the Hope Lab survey on food insecurity and housing insecurity, but I hadn't heard about this one from the Healthy Minds Network.
Sure. So our team works with a representative on campus, whether that's a counseling office, the registrar, to develop the sampling frame. The sampling frame typically is for larger schools, 2,500 to about 3,000 students. For smaller schools, it can vary a little bit. But once we've done that, once we have the list of students, that we're trying to draw from. We'll use a random selection procedure to reach out to those students. It's usually in concordance with some messaging from the college or university that's participating with us. So it might come from their Office of Student Life. But then we work with participants. It's a Qualtrics survey that they're responding to. So our sampling strategy is in some ways dictated by our partners in terms of the student list that they give us. But that's the way that we approach it once we have those lists. Did that answer your question?
Yes, it did, but I have one more follow-up. How do we get on that list? Be interesting to have the survey, and then we can use it for some decisions based on the data.
Right. Well, so I'm sorry. Please. Did I interrupt you, Lisa? I'm sorry. So, I mean, the survey itself is available for anyone to download. You are welcome to pull it for the website. If you are interested in trying to bring Healthy Minds to your university or to your college, we are happy to have those conversations. We do charge a fee to provide the services, mostly for the administrative cost of the service, but we work with schools to make that possible. And we understand that for many schools, the resources in order to provide this survey might be scarce. And so we can have conversations about what we can do to help you bring this, or even to conduct something similar on your own to campus. So I'd be more than happy to have a conversation with you about what we can do if you're interested in bringing this to campus.
I was just going to say hello. This is Mara. We are from Cape Cod Community College, and we did the Healthy Minds study at our college like in 2018, and we have all the data, but I like the way that it was presented here, because when we got our printout of it, I don't know that I'll have to get someone to break it down into ethnicity and stuff, and so my concern is I don't know if you can see the data from BIPOC. I see that only 9% of the people that filled out the survey identified, as African American, and then 9% Hispanic. But I don't want to misconstrue the information. I wonder if there's a way to look more into the data and see if we can get more of a standing of which population filled out what answers, and maybe that would help with our data. And just for Lisa, hi Lisa, I see you at another meeting. We also did it through the JED Foundation when we were starting a project. So we're pretty excited, and then there'll be a follow-up study in 2 years. But really interesting, Justin, how you presented it. Would love to see if I can get into the data more and come up with the answer.
Yeah, it's a good point. Very nice to meet you. I would say feedback is very much appreciated. So what we've dedicated a lot of time and effort over the last couple of years to create a website that would allow people to pull data and to generate some of this information and some of these reports. That might work for maybe prevalence estimates or population level estimates, but when it comes to specific schools working with their data, there might be I guess I'm thinking scripts that we can help to develop so that people can run reports more easily. So we're not just assuming that each participating institution has a data manager that can spend, as much time as we get to combing through some of the data. So I'd love to hear some feedback, and maybe we can chat offline about some of the questions that you're trying to ask. And if it's pulling data like this, we can maybe give you some guidance on how to stratify your sample and get some of this information.
Yeah, because for me, it was like 70%, 77% white filled out the survey. So if I'm making the comment that, X amount attend wellness or mental health services, it doesn't really help me to determine whether or not our BIPOC students are part of that percentage or how many of them actually do it. So it would be interesting for me to try to niggle it down to that.
Yeah, please feel free to reach out, and we can we can see if we can help you get to where you want to.
I guess my question would be, because I'm big on the numbers thing, is if you present it as such today, is it truly representative of the people of color that would use the services, or are you just taking the top number?
No, yeah. So representativeness is a big concern for us. So when we present our data, we provide both raw data as well as survey weights, so that we can try to have, when you talk about aggregate estimates, you're essentially giving more value to under respondents. And so you can compare what we think would have happened if you had the entire population at a specific school or across the country relative to what we see within the raw data. In some cases, our approach has been to oversample particular subpopulations of interest. So at times, for example, at U of M, our Healthy Mind survey, we've oversampled Asian American students, or we've oversampled African American students, because we're specifically looking for those voices to be represented within the data. And so that's a strategy that could be implemented too, again, working with specific schools about their individual needs and how we would sample from our student population. But just because we even oversample, one thing that we do know is there's often underreporting from our non-majority students. So we have just lower response rates. And so what can we do to encourage students to speak up? And that might be true too of our community colleges in general. The response rates, they vary quite a bit across institutions. But trying to improve response rates is going to make that generalizability question that you asked less of a concern.
Okay.
Thank you so much for these really thoughtful responses and for your presentation. I was watching people's faces as you were speaking and seeing a lot of nodding, a lot of recognition that this data aligns with so much of what people are seeing in their daily work. And I know that there is so much more to do. So I want to make sure we stay on track to move into our small group sessions, but please know that in the resource list that we'll be sending out after today's event will include contact information for everybody who has agreed to share their contact information. And we will also have some additional resources and ideas around where to look for training and technical assistance around disaggregating data, moving beyond the Healthy Minds Network study, since that is so important to understanding how outcomes differ for different groups of students within your institutions. So at this point, we're about to move into breakout groups. We have assigned moderators for each breakout group. And the first thing that we hope you'll do when you get into those groups is volunteer or voluntel a group member to serve as a note taker and as a person to report out as the spokesperson for your group when we reconvene. We are going to stay in our small groups until 2:35. Then we'll take a 10-minute break. And when we come back, we'll be back in this larger room right at 2:45 to continue our discussion. So Vanessa, do you have any instructions for us to navigate this journey to our small groups?
Yes, hi everyone. So I will be moving all of us into breakout rooms. And then once the breakout room is about to end, you'll see a countdown on your screen. And then we just ask that the facilitators who are helping us today to record, if possible, our discussion so that we can have the notes. And then again, I'll be here if you have any questions, any technical difficulties, I'll be able to help you.
Wonderful. Thank you so much, Vanessa, and everyone. We'll see you in a minute in your small group. of you are taking the time to connect in this way. I know we're waiting for a few of our colleagues to rejoin us in this larger group. As they do, we're going to get started with some conversation. And I think for now, we'll keep the slide deck off to the side so we can see each other. Vanessa, I really appreciate that you're taking notes off screen. So we're going to try and capture as much as we can from this discussion. So for starters, I'd love to hear some of the key takeaways from each of your groups, anything that was surprising or really rose to the top in your discussion. And maybe we could start with, I don't know, Dory, if you selected a spokesperson in your group?
Yes, we have a spokesperson. Lisa is going to speak for our group.
Great.
I don't know if she's back yet. Is Lisa here? She doesn't appear to be back yet. So
Okay, well then we can hold off for just a moment.
yeah, wait.
It's only 2:46. Hi, Lisa. We were just putting you on the spot. You go first with sharing. So
Yes,
you
yeah.
from your group.
Kind of the key takeaways, Lisa, that we talked about in our small breakout room.
Unmute myself. So what we talked about, we had some targeted questions that we raised. And so we talked about some specific best practices on engaging the faculty and staff around letting them know about the supports at RCC. We don't have a clinical person on staff that provides counseling, even on a short-term basis. But what we do in Project Access is that we make referrals, and we have a toolbox full of resources in the community where students that are at that point where they're ready to seek assistance, we try to make them feel, welcomed, and try to, specifically look at what they want to focus on and who they'd like to work with. We understand there's no one size fits all, no cookie cutter approach to services. And so if a student says, well, I want someone that is, Haitian background and can relate to me as a Haitian student, Haitian Creole, or if they say, I want someone that can help me with some coming out issues that I'm having, et cetera, et cetera. So we try to really engage the student and let them be the driving force on their path to wellness. And we just try to offer that support. So we try to find those key clinics or organizations that have a proven track record of giving students support, because we know the last thing we want to do is make a referral or have a student get in contact with someone and they don't take their insurance, 2, they may not be available on, the times a student has available, like nights or weekends, et cetera. So we really try to let them be a part of that process. And then we talked about how to, like I said, engage faculty. One of the ways that we do at the college is at the beginning of every semester, the day before classes start, I will be asked oftentimes to do a short presentation to the returning faculty as a reminder, the new faculty, to get them aware of what services that we provide, non-academic support to students, as well as I've given the students information from this office to the faculty to ask them if they would include it in their syllabi. So in that way, there's a blurb, to let students know that we're available. Yes, they have tutoring. Yes, they have accessibility services, those resources available, but to let them know that this is also, there for them if they happen to be struggling in any way. So we talked about also the impact that and reasons why, as an offshoot of the earlier discussion about why a lot of students don't engage in any type of support. And a lot of times it's cultural. Their background's prohibited. There's, family stigma that says you only talk about family issues or things going on with you with the family, or you take it to our higher power. If they happen to call that person God, you take it to God, or we'll discuss it around, the dinner table. But there's certainly a lot of reasons why students don't seek help. We talked about one of the group members mentioned that they were at a presentation and they found out that peer-to-peer counseling was very useful because it oftentimes, they want to talk to a peer that's maybe in the same age group and maybe struggling with the same types of things. And we also talked about how pandemic has really just taken the lid off and really shown a spotlight on the challenges that our students are facing. And now, especially in isolation. And so how a telecounseling program would be beneficial. And so whether it's a peer-to-peer or whether it's specific towards getting them directed to a clinician, then whichever one, but we know the importance of doing so and how a lot of times there have been student-led groups like the one at BU that went to their administration and said, look, we really need to have people that look like us in the counseling center. And so they pushed for that and they advocated and they were successful in making that happen to benefit all the students in the long run. And so we talked about that if colleges were to just take that step, that it would be really a retention initiative, a retention tool, because if you can keep students engaged and focused and giving them the support, then you're going to retain those students. You're not going to have the dropout and the stop outs and the withdrawals and those types of things that we often see on our campuses. And so those were the types of things that we talked about. Dory, did you want to add anything else?
You just provided an as I'll use Sherry's word, insanely excellent summary. That was great. That was really great. And
thank you.
Very good job.
Well, yeah, it sounds like a really great discussion that you all had. And so Lisa, thank you for starting us off in such a strong way for this aspect of our discussion.
Sure.
Juan, did your group identify a spokesperson?
Yes, I self-identified as the spokesperson. After consulting with the team, had a wonderful, rich discussion. Amy Gatto was part of the conversation. Amy Stewart, who had to leave early. Amy Stewart spoke about the work, the clinical work supporting an immigrant student. Julie and Jason also spoke from the angle of the respective community colleges. The discussion was very rich, so I'm going to barely summarize some of the points. I'm sharing my screen right now. Some of the highlights I have is first what Jason said around the need to advocate for more resources and being against this model of you should do more with less. Community college is a way to use this dynamic from the times before the pandemic. Some creative solutions that are being implemented, like bringing VA, AA, NA, or LGBT community related services to campus and utilizing, the assets like space and ways in which the community college can serve as a public forum for these communities to connect with each other. Wellness workshops and classes. Julie spoke about one of the, workshops and classes they have for first year students, like a passport program or bridges course to teach students how to stay well. I strongly resonated with this. Chelsea and Dory know, because that's all what we do at the Center for Psychiatric Rehabilitation in terms of connecting with students along the lines of balancing your academic resiliency and your wellness. Therefore, I think that's just phenomenal that community colleges are working in that respect. Some idea was floated around to bring a traveling counselor serving a network of community colleges. Jason spoke about having under-resourced, like one clinician for 4,000 students, which is completely amazing of a number, and ways in which Jason's community college is responding to the high need and the need to be nimble and flexible. Amy Gatto shared a resource. I'm going to try to see if I can show you from JED, which is creating a culture of caring, which reminded me also of a recent training we attended in one of the colleges in Texas, the Amarillo College, 10,000 students college, that it's implementing this wonderful mental health first aid training for all staff to normalize the access to the conversation. And the group, it was talked that, many times faculty may feel nervous about handling a mental health related conversation that's kind of way out of the scope of practice, or things might turn into kind of suicidal right away. So normalizing and teaching staff on how to respond. I think these are interesting best practices that are being put out there. So I would invite Amy and Julie, who are still here, to add to my brief summary. But again, the conversation was rich, and I'm in awe as to how much community colleges are doing with limited resources. I think that's just outstanding.
Thank you so much, Juan. Amy or Julie, did you have anything you wanted to add to Juan's summary of your conversation?
I was going to say the only thing I was going to add is again having someone that can access the area resources that don't necessarily cost money, right? We talk about the AA and the NA groups. I think also agents that get underutilized are spiritual programs in communities, even in rural small communities and larger communities. And I think sometimes people kind of shy away from that, but I think you just make it open. And I think you do have to do a little bit of investigating to make sure they're safe and appropriate and whatnot, but to have them and because that is important for a lot of our students. And those aren't necessarily ones that are going to cost anybody money, but there are other resources. So it's not, right, we talk about mental health, and we believe in holistic health, right? Mind, body, soul. So it doesn't always mean a mental health counselor, right? There are other folks that have the skills and abilities to support students' overall well-being. So.
Such an important point. Thank you, Julie. Great. All right, John Delman, do you have a spokesperson from your group? Uh-oh, you're on mute.
Yeah. I'm the spokesperson from John's group. So, but I think I'm just going to piggyback off of what Julie was mentioning, and really kind of talk a little bit about this cultural shift of what mental health is, right? And the stigma that comes along that with many of our students. We discussed before of what that means for different cultures and engaging in mental health and counseling and reaching out for help and the challenges that come along with that. So one of the big things that came up for is, wording matters. How are we intentional with the language we use, whether that's the office's names, whether that's in our syllabus, whether that's in our advertising. We talked about how that's just not going to be an overnight change. That's going to be a cultural shift for the institution. And I think that's not only on the wellness staff, but that's also on folks like me as an administrator, as a dean, to really kind of make sure that, in many of these areas, they're only one person operations, right? So how is mental health everybody's responsibility? And really kind of champion that work for everybody. How do we train? Another thing is, how do we train our faculty, right? How do we continue to work with our faculty? Not just the one-off that we always are invited to do, but how is it consistent training each semester or professional development or a faculty interest group perhaps that we can kind of maintain? And then how do we get those folks that aren't involved in those part of that, right? Because we always have those champions that are going to attend all our events, but what about the night and evening folks that, aren't on campus? I think one of the other things that came up was just about being engagement of students being a little bit more intrusive. Whereas, we're texting, we're calling, we're emailing a lot more with these students. And it may take more than just one interaction. It may take 7 or 8 interactions just to get a response from a student, because we know that many of our students, their lives have shifted when the pandemic hit. School was 4th on their priority list. Now it's 10th. Right. So, I think that's something to be mindful of. Just going back to the diversity of staff and the strain on staff, I think that's an excellent point. And how do we make sure that, we can partner with community agencies for referrals and perhaps develop new partnerships with cultural organizations, perhaps to provide some supports, for our college staff. But I think those were the main things. Having courageous conversations about race, about, being honest, about, once again, going back to the staff diversity, that perhaps I may not be the right person to talk to, but I want to let you know that I do care. And far too often that's a hard conversation because, but we're inviting students to make that decision for themselves rather than assuming. So I think, I don't know, for my group, is there anything else that I left out or anything else that you wanted to emphasize? I think that's it, Valerie.
Covered it well, very well. Thank you.
Thank you. It sounds like a great conversation. John Dunkel, could you report out for our group, please?
Sure. So there were a lot of similar themes in our group. The one thing that I would just say up front is that, we need to also think about mental health on a continuum. We're at one end, people are doing just fine. They might have some stressors all the way down to mental illness. And that when you think about it that way, sort of like with physical health, the vast majority of students are not going to need a mental health professional. There's lots of other things that can be done. And so when they do need a mental health professional and have mental health issues or mental illness, mental health conditions, one of the themes that came up is the issue of, the shortage of clinicians of color, particularly at the doctoral level. And then, the struggles of being on a campus where it's predominantly white. What does that mean? I also would throw in there, one of the points I brought up too is BIPOC is a very broad group. We need to be thinking that, the experiences of Black students may be very different than those who are Latinx and those who are LGBTQ, and then the intersectionality. We need to really get into the weeds to really understand what are the specific issues facing the students face based on their race, their ethnicity, et cetera, other cultural issues. So Melissa made a really good point. I love this. She said, we have a diverse student population, but our staff and faculty are not necessarily matched that diversity. I know I heard that a lot in my work in higher ed, still hear about it now. Big stressors around money, survival, managing responsibilities, predominantly being commuter campuses. So it's more of a challenge to really do programming and reach students in ways that one might do, an institution might do if we had a residence hall. It's a very different set of challenges. And then if students are coming on campus and leaving, maybe they have to work, they have family responsibilities, they may not be able to get engaged in student groups or other types of programming. So it's much more of a challenge. But creating safe spaces, we hear a lot about that. The idea of safe spaces on campuses for BIPOC students and LGBTQ students, it's really a big issue, and it really sends a very positive message to students when campuses invest in those safe spaces. JED, someone mentioned the JED equity and mental health framework. That's something that we partnered with the Steve Fund to give recommendations to campuses on how to make sure that you're addressing mental health in an equitable way and thinking about culture and race and ethnicity and other types of things. So, and then getting faculty involved, we talked about that. That's a big one. And we talked about how are students welcomed? Is there orientation programs? Let's see. The other thing, I didn't bring this up in the group, I'll bring it up now. The other thing that's even more important, I think now, is this whole idea of trauma-informed programs, services, policies, systems for campuses, particularly in light of all the racial injustices and that's been going on in this country for a long time, but especially in the last year, and what the impact that it has on our students of color, particularly our Black students, having a trauma-informed approach to our services, our programs, and our policies is really critical. So did I miss anything? I hope I captured it okay.
I think that's a really good summary, John. I don't know, Maura, Melissa, did you want to highlight anything that maybe John missed?
No, I'm good, thank you.
Maura took great notes.
Thank you, Maura. Great. Well, this This is a lot of really, really great information that Vanessa and I are furiously scribbling down and looking forward to cleaning up and sharing with all of you after this event. I mentioned as we were getting started that our whole purpose as an MHTTC is to provide training, technical assistance, consultation, and support to the people who are really out there doing the work every day of meeting the mental health needs of people in New England. And in this case, we're talking about meeting the mental health needs of people in New England who identify as BIPOC populations and are enrolled in community colleges and experiencing some mental health needs. So I'd love to shift gears for this next bit of our conversation and really get some ideas from you around what kinds of training or consultation you think could be most helpful in addressing some of the gaps that you're seeing, some of the challenges that folks are facing in their daily work.
I'll pipe up. I know John mentioned about trauma-informed care, and I would like to see our faculty having that more essential to their onboarding or professional development. So many of our students have faced trauma, and it can make such a difference the way the faculty responds to them in that moment and keeping them in school. And I think it's underestimated the effect that it has on our students. And so I think if we could get that more as a regular training for faculty, I think that would be great.
I think there, oh, I'm sorry, continue.
No, go ahead, Terry.
I was also just going to add in my group with Lisa and Dory that social media is also a really big component, especially towards the younger student population in terms of access and also representation too. Just to see counselors who look like the students and understand where they're coming from, and that they can reach out to them in a multitude of ways. I know that BU did a social media campaign and it worked for having students feel like they are more invited and included in that important sector of their school life.
I think one thing that we didn't speak about was also the support for our clinicians and our staff in our wellness and counseling areas, right? And how critical that is. Far too often we put so much pressure on them, but we never check in with them, right? And I think that's one of the most critical things that, we could probably do a better job of that, where if they're not well, how are they supposed to support the wellness of our students? So.
Brian, I'm so glad that you raised that, especially in light of how many folks are working as sort of one person wellness shops and holding all of this responsibility, all of this concern for huge populations of students. I'd love to hear a little bit about sort of what's working now in terms of support for those of you in those roles and others in similar roles that aren't part of this conversation today, and what's missing.
I'll just share from when we transitioned to remote learning that we lost a counselor to COVID. And, that took a heavy toll on our wellness staff and counseling staff. So it was my responsibility, right, to check in and to constantly, be there for support and make sure that they were ready to move forward, right? And then more recently, we just lost our director, right? She resigned. So I think it was one of those where how do you continue to maintain quality services and pivot and transition as all these other factors come in, right? So it comes down to also what leadership looks like and what their supports are. I think far too often it does come down to that, but how do they make mental health a priority for the institution and the support that they give?
No,
if
I would, can I just build on what Brian was saying? I want to underscore the impact on staff, particularly staff of color. Oftentimes, what I hear about especially in counseling centers, staff of color, a lot of students will want to see them specifically. And so the staff get really burnt out as well, because the rest of the staff also need to be brought along. And it's not about just learning, multicultural competencies, that type of thing. You have to get out in the community and meet the students so they develop trust and feel safe with you. And so I found that was an important part of what impeded a lot of students, is they just feel like they didn't trust, particularly the white clinicians on our in our staff or otherwhere in other centers. And so, but getting out in the community and really interacting with students in their safe spaces is a big part of a truly trauma-informed and multiculturally informed approach.
And if I could also jump off of what Brian was saying and have more of a question, and someone mentioned moving away from the model of doing more with less. And I think this is a really important place that we need to, think about, or I hear more about, in terms of, how do we get the attention of the state legislatures that are doing the budgets. We obviously, data is going to be important, but how do we do it in a way that's compelling, that they're willing to make an investment, right? In community colleges in general, if we're talking about a holistic approach, community colleges provide so many different aspects of well-being for their student population, and they play such a vital role in our communities, yet they're so underfunded. And so, I'm curious to hear if anyone's had any successes. Juan referred to, we listened to a community college person from Texas talking about that they've been, during the pandemic, they've actually retained and increased their student body, and they're using that data to convince their funders to keep paying. But how other people are doing it, or what are the walls that you're running into around the funding issues, and this idea of that, well, you should do more with less, when we know that that's just really not possible.
I mean, I think it's being strategic, right? So, for instance, we get CARES money. So, there are obviously limitations to that, and they give you a whole bunch of money, but then this is where you can't spend it on, right? And this is where you can spend it on. Oh, and by the way, by May, it needs to be all spent, right? So how do we make strategic investments and ensure that next year, when we do continue to do the work that we do and perhaps enhance some of our services, we can maintain that? So I mean, I think the biggest challenge is the leveraging and the collaboration. For these one-person operations, I've challenged many of my directors to work together to support mental health, and everybody see it as their responsibility. But those are small steps, right? And like I said before, we were talking about cultural shifts in the institution. It's going to take time. So I think that's one thing that we have to constantly be champions of and build and search for new champions to continue that message. But the funding issue, how do you work with your advancement team? How do you work with your development team to tell the story? That's their role, but we're here to provide that data. I know before we were talking about data and what do we do with it? Well, how do we collaborate to make sure that we can get the funders and the folks that are interested, to work with us? My biggest ally is our development team. They're finding monies for me left and right and grants to kind of support what we do. So I constantly have a monthly meeting with them just to check in and say, okay, these are the initiatives we're looking at, or what did you come across that perhaps can help us?
Great. Leaving no stone unturned.
I was going to say from kind of going back a couple of questions before, as a director of a counseling center at two different institutions, one of the things, when we talk about educating faculty and staff on how to support students, and I believe, and again, we've done mental health first aid and trauma informed, sometimes it's too much. Does that make sense? It's almost too much for faculty and staff. So what we have found is to really keep, I call it, the keep it simple, keep it simple, sweetie method. And we give them some really basic tools. And I know there was like a pamphlet, a handout that was sent. We created our own, how to recognize students in distressing patterns, but really super basic. I mean, just do mindfulness. And I always tell, so it's also for them to take care of themselves. And I encourage, faculty and staff not to overthink some things, because sometimes things are, keep it really basic. And I think they are often looking more for quick tools. And I don't think that's a bad thing. Here's a quick, a little handout card. These are 5 real things that you can do in the moment. When you're Zooming with 15 students and one's, crying their eyes out in the middle of a Zoom. Here are some quick tips you can do either in the chat or follow up with them later. Right. So those are, suggestions I have. And, as a director of wellness and counselors, and having experienced, unfortunately, grief and Brian, my sympathies to you and your team. It sucks. I mean, I got to be honest, it really does. And yet, as the director, I have found it is my responsibility to go to my administrators and say, hey, I just need some thank yous today because it's been a really crappy 2 weeks. And it took a little doing for them to hear that, but and then to use our humor. I mean, I use this term very openly. I'm a very blessed director. I have some phenomenal people on my team. So we have really worked on, since we're not always going to get it externally, we work on our internal gratitude and things like that. So.
You just shared so many great ideas. Thank you. And your idea of these these really quick resources that are accessible and demand very little of faculty, but can be exactly what they need in a given moment. It sounds like you've developed a lot of those and had some experience rolling those out. Are there any that you'd be willing to share with others in the region to maybe play with at their campuses?
If I could figure out how to do it electronically, that is not a gift and skill, but yeah, we have our little distressing pamphlet and things like that, but it does have those. And I'll have to figure out how we broke them down into little cards for some people. So someone will have to give me an email and I'll figure out how to attach it and send it.
Yeah, I mean, I think what I'd love to ask all of you is, we have this set of resources that we'll be sending around after this meeting. But I know that within your own work, each of you is also developing your own resources all the time and coming up with great ideas and great approaches. How can we help to foster sharing some of those? One quick and easy way is I'm happy to roll anything you want me to roll into our resource list and send it out to everybody. But I wonder if there is any interest in more sustained kind of sharing of information or emerging practices or ideas or support.
Well, I also think it's important for various professors and faculty, I'm sorry, to regularly maybe meet to kind of discuss anything that they've seen that could inform a trend in terms of the mental health of the students, or if they found something that didn't work and they want to pass that advice along. I'm not sure about the mechanics of all of that, but I think in general there should be at least a monthly Zoom kind of progress check-in meeting, not only to discuss those things, but also the mental health of the practitioners themselves.
Thank you. Any other thoughts or ideas around what may be helpful moving forward? It's clear that there's so much expertise in this room alone, and never mind all your colleagues and all the others doing this work. Any final ideas around recommendations or ideas for future connection learning opportunities?
Valerie, I wonder how we continue this conversation, right? So it's just not a one-off, right? I think far too often we just have these conversations when the topic's ripe and big, and how do we continue that, right? And I mean, I don't know if they're formal or informal ways to do that, but the conversation matters, right? And how do we expand this group, right? To get some more champions around the work that we're doing. I wonder what the next steps are, or what next steps are.
I would like to chime in. Mara and I are part of a statewide coalition of SPOCs, which are single point of contacts for housing and food insecure students. And so we meet monthly and we share resources, ideas, best practices on how to work with students. And so we quite often will bring in knowledgeable professionals in those areas. For example, we'll bring someone in from the state that can talk to us more about SNAP resources or about those types of things affecting students, in terms of resources. So a lot of times to bring in professionals, but to continue our discussions, but bring in other professionals from time to time to kind of give us, share more information. So maybe we could consider maybe doing maybe bi-monthly or monthly or quarterly or something, but maybe I like the idea of monthly, but people can chime in and come on into the meetings when they can, but to try to have something consistent.
So I have a question because I'm not sure. Is everyone from different parts of the country, or are we all in one state?
So we invited folks who are working at community colleges in each of the 6 New England states.
Okay.
And then we also have some national experts who were joining us. So for example, Justin, who came in earlier, Brian, I know you're not in New England, but for the most part, we're focusing on folks doing this work in New England.
Okay.
And just to add a little bit about it on the role of the New England Mental Health TTC, we have 2 initiatives that may be of interest for this group. So I'm really we're hoping to create, continue this conversation, as some of you have said, because the expertise is really rich. There's going to be a wellness initiative that we are all going to be studying in terms of, I know some people were talking about compassion fatigue and other things. I was reading the text. So feel free to take really use the opportunity that we offer the New England. These are all free opportunities that New England Mental Health TTC offers. In addition to that, we are seeking to do a learning collaborative around social justice, racial equity. And it just occurs to me in the conversation that which was very rich, and we were talking about the disparities and the importance of flexibility and the responsibilities that BIPOC communities have, and language issues and culture, all these issues that we were talking about, that it will be neat to maybe do some more exploring about maybe targeted learning around these issues as a group and bring in different expertise, like the one we have here. And I know just by hearing each other, I could see how there was already learning happening from people working, in one program to the next. But there is a lot of things we talk about, partnering with each other, with the students, being flexible, caring, all those things. So I'm hoping we're gonna be able to, we can expand it to this group, but definitely just create something specific around this would be fantastic.
I love that idea, Maria. Thank you. So I know that our time together is drawing to a close. As I mentioned earlier, we'll be sending around some resources, some high-level notes that try to capture some of the themes that you all shared today, and also an invitation to participate in a little bit more of this collaborative discussion and strategizing moving forward. We also did want to share some information about upcoming events that the MHTTC is really proud to offer. I'm not sure if these are showing up well on your screen. They look a little bit small on mine, but we'll also be sending around the slides, so you'll have those there, and you can of course access these on our website. Vanessa, do you want to just show our contact information again? I think it's a previous slide. There we go. So again, I'm Valerie, and I'm really pleased to be the point of contact for continuing this discussion. So please reach out to me with your ideas, questions, reactions. And you'll also see some communication from Vanessa very, very soon with the follow-up materials that that we discussed. And we have Justin's information here as well. I know several of you are already really pretty involved with the Healthy Minds work or knowledgeable about it. But certainly he's available to answer questions and to orient folks who haven't had the opportunity to get as involved with the Healthy Minds network. And some of the questions that came up earlier as well around other ways to approach disaggregating and analyzing data that you're collecting in different ways on your own campuses to really zero in on some of the needs of BIPOC students and particular subpopulations of students. That's something that we'd be very happy to help with consultation or technical assistance on as well. Any last comments or words of wisdom before we wrap up? All right, in that case, thank you all so much for taking this time. It was really a pleasure to meet you. Be well, and we'll be in touch.
Great, thank
Thank
you.
you. Nice to meet you all.
Thank you.
Thank you.
Thank you. I love sitting in on this and learning everything. And, you know, I think it's a really great step for me to help learn how to help people.
We were so happy to have you here.
Yes. Thank you, Lisa, for registering me to come. I'm so thankful. So, all right. Everyone have a wonderful afternoon. Take a load off if you can.
That's the spirit. Thank you. Well, that was a really great group, right?
Amazing, you guys. Congratulations. What a great conversation.